Hello, everyone. Good morning, good afternoon, and good evening. I am Dr. Satyan Pathasarathi, glaucoma practitioner from India. It's my great pleasure to welcome you all for this webinar in the subspecialty glaucoma. We are focusing on the MicroPulse TLT laser therapy for the glaucoma, the experiences in India, United States, and United Kingdom. We have very experienced speakers from United Kingdom, Professor Philip Bloom, Dr. Cyril Dorairaj from United States, Dr. Alka Pandey from India, and also Dr. Sonal Chaya from India. So we have speakers who are going to touch upon almost the entire spectrum of how we are going to deal with this MicroPulse laser therapy. First, I'll be talking to you on the procedures. For the next 10 minutes, I'll be touching upon the technology, what is the mechanism of action, and what are the parameters, surgical guide, and also the patient selection criteria. So what is the technology involved? When you look at the 810 nanometer laser, diode laser, it is ideal for the soft tissue management. The 810 nanometer diode laser has two modes, the continuous wave and the MicroPulse. Continuous wave emits more thermal energy, causes more thermal damage to the tissues, whereas the MicroPulse minimizes the thermal damage. That's what we are going to see today. So this is the continuous wave mode, which is given for 2000 milliseconds, that is the 2 seconds duration, where the on time of the laser is 100%. The laser which we use, or many of us have used, and of course we are using currently also, is the transscleral cyclophotocoagulation, otherwise called as TSCPC. We use the G probe, and the new probe is called the G probe Illuminate. So when you look at this, the multi-pulse mode, basically we just chop this continuous wave into repetitive short pulses. The pulse, if you take a duty cycle of 1.6 milliseconds, then you can see the pulse is on for about 0.5 milliseconds and it is off for 1.1 milliseconds. So that is the total duration of 1.6 milliseconds is the duration. So what happens is, in this, we literally reduce the total thermal energy generated. So the total on time is only about 31.3%. That is what we call it as a duty cycle of per pulse. So this is 0.5 and 1.1, so total duration is only. So coming to this MicroPulse mode, we use this laser called the MicroPulse Transscleral Laser Therapy, MPTLT. We use the probe, the P3 probe. What is this P3 means? So it is the pars plana probe, the P3 probe, which is shown in this picture. The MicroPulse basically was introduced in the treatment of retinal vascular pathologies as the subvisible threshold laser treatment. Just look at this picture on your left. You can see that there is a retinal neovascularization and it has been lasered, but you cannot see any of the laser marks. And also on your right, you can see the red tree shows the deep layers can show the laser marks. It is the MicroPulse therapy. In contrast, you just see this, the continuous wave, how much of the scar it is causing. Onto the left, onto your right is the MicroPulse. So that is the contrasting pictures. What is the mechanism of action of this MicroPulse therapy? The melanin in the ciliary body epithelium is the target tissue where the MicroPulse focuses on. Let us see with the different power settings of the probe. Look at the 1.59 joules probe location. I'll just show you the video how much the ciliary body is working. The ciliary body phase and the trabecular meshwork works in this. So the laser is delivered on that. And just let's look at the second probe, which delivers the energy of 2.35 joules, which works on the longitudinal ciliary muscles, doesn't work on the epithelium. You can see this video. It doesn't work on the ciliary body epithelium. And let's look at another probe which delivers the energy of 0.08 joules. It just works on the shortening of the muscles. So these are the three types of probes which is being shown in these pictures. So what does this MicroPulse does? So the MicroPulse energy induces the constriction and the expansion of the ciliary muscle bundles that results in the aqueous outflow pathway reorganization. Ciliary muscles, shortening and constriction of that, what happens is there is an enlargement of the supraciliary space, enhancing the uveoscleral outflow. And also it works on the trabecular meshwork posteriorly, and there is an enlargement of the Slum's canal also happens, which in turn enhances the trabecular meshwork outflow as well. So just to re-emphasize, there is a tissue remodeling and the reorganization happens once you do the MicroPulse, which in turn changes the aqueous inflow as well as on the outflow facility. So enhancing that. Just let us look at the aqueous production, how it really decreases. It focuses on the thermal energy is focused on the pigmented ciliary epithelium, which absorbs the thermal laser energy, and it transmits to the adjacent non-pigmented epithelium, which produces the aqueous. By acting on this, the thermal energy works on this and reduces the aqueous production. So that's how the aqueous production is also reduced. So who should we treat with the MicroPulse laser therapy? I would say almost all types of glaucomas can be treated. They pre-trabeculectomy where the pressures are very high. Once you do the trabeculectomy, then you may have a lot of complications when the pressures are too high. So you can do the pre-trabeculectomy, pre-tube surgeries, failed mixed procedures, and also post-trabeculectomy is one of the patients where I have seen at least a great IOP draw, and also in the post-tube surgeries. Penetrating keratoplasty patients have the maximum benefit in our patients setup. Of course, we can do it in the pediatric glaucomas and all other open and angle closure glaucomas. Uveitic glaucomas and silicon oil-induced glaucomas also are the other few indications. So what are the parameters and the surgical guide? So I've given you two settings here. One is for the transscleral cyclophotocoagulation, which I'm not going to discuss now. I'm going to just focus only on the transscleral cyclophotocoagulation of MicroPulse P3 probe. The power settings is 2000. Those with a little bit of more experience or where you want to do the repeat procedures, you can set it up around 2250, but otherwise it is going to be 2000 is the milliwatts power with a duty cycle of 31.3. We'll just see that little later. What are the other parameters here? So this is the equipment, and you have the optional equipments like the remote control and also the wireless foot switch. And you can see on the right bottom is the Cyclo G6 probe. There are two different probes. In India, the first model is available, the second model is still not available. So just look at this probe. The tip has a notch. The notch has to be towards the limbus, and the flat side is towards the lid margin, lids. So you can see this towards the limbus and away from the limbus. just to re-emphasize how the probe has to be placed. So placement and the application, the G probe, the one which we use it for the TSC PC, is always focused towards the parallel to the visual axis. But when you're doing the MP3, you have to make sure that it is perpendicular to the tissue. We need to prepare the patients mentally as well as by anesthesia. We can give a mild sedation. We prefer to go for the peribulbar anesthesia, or one can prefer the retrobulbar as well. But the peribulbar is a must. At least the peribulbar is a must. Otherwise, it is a bit of a painful procedure. Initially, when we started, we were not using the coupling agent, so I thought this is important to emphasize the usage of the coupling agent, coupling solution like methyl cellulose, gonioscopic gel or lidocaine gel is essential. Otherwise, the energy delivered may not be good. You can just see that the spread of the light. Once you use the methyl cellulose, the laser beam is focused much better and the energy delivered is more effective. So you can use the probe in two different ways. This is one way you can apply. That is, you have to always make sure that they leave the 3 and 9 o'clock positions where the long ciliary comes in. So you can start from the 9:30 clock to 2:30 clock, and then below is the 3:30 to 8:30 you can use, as shown in the picture. You can treat with the two hemispheres, the superior and the inferior hemispheres. So just show you this. The upper part is, we have to use 5 sweeps superiorly. You can see the sweeps like this. 5 sweeps superiorly and 5 sweeps inferiorly with the 80 seconds duration. So 80 superiorly and 80 inferiorly with the 2000 power. Once you do the repeat, then the power settings can go up to around 2250. So this is how the procedure is being done. When you're looking at the quadrants, you can use a 4-quadrant technique also. When you do the 4th quadrant, you use only 5 sweeps per quadrant. Each sweep is about 8 seconds. The total duration and the power, there is no change. So I just used Dr. Chris' video as the video was much clearer.
Getting a cataract surgery with a toric intraocular lens and the MicroPulse laser system. For this patient,
so this is how the procedure is being done. Truly speaking, anybody can do this procedure. Even the OT staff who is assisting us can do the procedure. So it's not a big procedure that somebody has to really learn. Critical is the post-operative period. It is important that we have to advise the patients not to stop or discontinue the anti-glaucoma medications. That is the primary focus I wanted to tell. Second is on the topical steroids and cycloplegics. We use it for 10 days. Some patients, we extend it for another additional of 1 week to 10 days. Analgesics, again, is a must. Otherwise, this is a painful procedure. So analgesics, we can give either as a tablet form or sometimes we can give it as an injectables. So this is the last one. We have to go for the retreatment in some of the patients at least. So the retreatment can be performed after 6 to 8 weeks of your initial treatment once you feel that IOP control is not adequate, or if you feel that the procedure, the first procedure is failed. So I wouldn't take much time to wrap up my presentation. Thank you so much. I would like to acknowledge Dr. Prasanna, Team iRedux, and also Mr. Rachit Bandari from Biomedics India. Thank you all for your presence. Your presence is much appreciated. So we have all other speakers here. I will, if some of you have the questions, please post your questions. I'll be more than happy to have your questions. Please post it in the chat session. Without much delay, I would go with our second speaker, who is a really very well experienced person in the cyclogesics procedure from US, Dr. Cyril Dureraj. He's a professor of ophthalmology from Mayo Clinic, College of Medicine, and he's a consultant, glaucoma consultant. Over to you, Dr. Cyril.
Thank you, Dr. Satyan. So you gave an excellent prelude about the patient selection, the versatility, and also like, especially in this unpredictable times, if you have to go depend on something which is time tested, we always would go to something which what we learned. In my experience, if I have to go and see what I've learned, and then if I have a problem, if I have to go back and look for a solution, I would always go ahead and think of trabeculectomy. That would be my first choice if a patient is progressing, and then if I have to do a surgery to control the glaucoma. But in this unpredictable time, can I depend on this for efficacy? Yes. But unfortunately, if you look at the safety of what I learned, it's not that much. So the safety of trab or tubes that we typically do, over time, you can have complications. Up to 9 to 10% of patients will have some vision-threatening, blinding complications. So that's where the new MicroPulse transscleral laser therapy comes into picture. I've introduced this, I offered to my patients starting in 2015. And then, it kind of like picked up, looking into like, can it be offered to patients who are about to get filtering surgeries, something like trabeculectomy or a tube. If they have to get this surgery, can it be offered, especially in times like this, can we do something which is much more safer, and can it be done in all kind of patients? The one thing about what we learn typically is like whenever we do a continuous wave cyclophotocoagulation, we typically pick up patients who are in advanced glaucoma, that they have quite a bit of vision loss. But we wanted to look into options, whether this MicroPulse translaser therapy can be used in patients who have good vision. That's the major thing. But if you see at the literature that's been published so far, starting from 2015 when it was introduced, there is almost like 70 to 75 publications out there on PubMed. But unfortunately, there's not many publications. I would say not even 1 or 2 publications on MicroPulse being used on patients with good vision, especially like patients who have good vision better than 20/60. So this became our goal. Like we wanted to see whether this can be done much more safely in those patients. So we, like me and like Sandy from sunny Buffalo, we wanted to come up with this project. And then we kind of like enrolled patients who had best corrected visual acuity better than 20/60, and they had a minimum follow-up of at least like 3 months. Patients who had previous history of ocular trauma or anything like a congenital chamber abnormalities were excluded. This is my institution, and this is one of my colleagues. I know like during this time, during the COVID season, there's no more touching, but this is one of my colleagues. The basic idea of looking into it is like we kind of like wanted to check the IOP, how it measures over time, glaucoma medication, and then the visual acuity. We kind of like said like what would be the complete success? Complete success is someone who will have an IOP better than or in between 6 to 21. And then the vision should not be like the complication-wise, vision should not be greater than 2 lines lost. A qualified success is like we kind of like enrolled patients should have met their IOP, but not their vision complications. So what did we see? So we kind of like enrolled almost like 61 eyes of 46 patients between these 2 centers with a mean age of 68. I want you to focus on this, mean age of 68. And we had a follow-up of almost like 10 months minimum, ranging to a little more than 1 year. And like I also want you to stress to look at this, almost 75% of our patients had no previous incisional glaucoma surgeries. These are patients who are about to undergo a incisional surgery. Like these are the patients who didn't want to undergo incisional surgery. They are almost like progressing, they're losing vision, but they wanted to try MicroPulse. So if you look at the patient population, most of them are Caucasians, almost like 50 to 85% of my patient population are Caucasians, and few of them are African American. And if you look at the lens status, almost 40% of my patients are faking. They didn't have cataract surgery prior. So the surgical technique is exactly something what Dr. Satyan described. We used like 80 seconds, almost like 2000 millivolts. I use typically the same settings for all my patients. It's almost like 10 seconds for hemisphere and making sure there's plenty of lubricants or like viscoelastics out there. Then what did we see? If you look at the results, I'm just going to run over the results. From month 1 to almost like 12 months, almost like 85% of our patient population kind of like succeeded in keeping the pressures in what we kind of like wanted it less than 20%. Why did we prefer 20%? Because according to the FDA, they say if you want to do a procedure or a medication or anything like this, they should have a better IOP control greater than 20%. The next thing is glaucoma medication. If you look, almost again, 80% of our patient population were off at least like one medication by end of 1 year. And then vision-wise, there was no significant reduction in vision between what we started and at the end of the study. So like if you look at how much the pressure dropped, if you look almost, if you compare it, it was almost like efficacy of almost like 40%. 40% reduction in pressure, almost like one medication was like lost. And then one thing that I want to bring up to your notice is the vision loss. Almost like 10 patients had some changes of vision, almost like 20% of my patient population. What did they have? If you look at the vision changes, almost 5 patients in my patient population had some sort of like cataract progression. And then they underwent cataract extraction. But if you look at the patient population, I just kind of like reiterated, almost majority of my patient population is like around 60, 68. If you look at the average age of patients who undergo cataract surgery in the United States, it is somewhere between 65 and 70. So to our best argument, like these patients who are about the verge of getting a cataract surgery with MicroPulse or like some sort of like a bigger intervention because they had a greater progression, they kind of like opted to try this as a safer procedure. Though they had a good outcome in terms of like reduction in intraocular pressure, we did notice some changes of cataract progression. And also like one patient had a CME and then 2 patients had iritis and 2 patients underwent some sort of like a progression over glaucoma, but not major any complications. If you compare with traversus tube or any other complications, none of those major vision threatening or blinding complications were seen in our patient population. So success-wise, at the end of 12 months, almost 75% of patients had complete success. And almost 93% of these patients had IOP well controlled. So when you compare with an incisional surgery, like a trab or a tube, so what is the comparison? If you look at the landmark TVT study, almost 51% reduction in intraocular pressure in the TVT study. But in our study, we had like almost like 40%. It's like, you know, life is all about compromise sometimes. You know, like you have to give in something to take something. Here, we kind of like compromised on a 10%, but like the safety-wise, we didn't see such vision-threatening complications. But there are other publications which is already on the PubMed, which kind of shows almost 51% reduction when you're using the MicroPulse in these patients. How about safety? Greater than 2 lines, if you compare with other studies, we had almost like 20%. But when you compare with TVT studies, almost like 32 to 33% vision loss in those groups. But we didn't have, again, such major complications that I would be worried about. So the major advantage in my patient population is almost 75% of my patients who are at the brink of undergoing a trap or a tube had some sort of like a benefit for 1 year. So this is one of the major, again, take-home points. So in this situation where Dr. Bloom is going to touch upon the COVID pandemic and what is the advantage of using MicroPulse, here it eliminates a sterile operating room, provides less post-operative activity restriction. Patient comes in, get the surgery done or the procedure done, and then I see them in a week, in a month, and then we kind of like follow them without much complications. But the limitations of the data is it's retrospective, short duration, and no comparative group. So to summarize, MicroPulse should be considered earlier in glaucoma management and can possibly be offered as an alternative to incisional glaucoma surgeries. It's quick and relatively easy to learn, but as Dr. Satyan was saying, even as technicians can do, but my point is to have a predictable outcome in your patient. This is something like an art. We have to learn and we have to do it more. You have to practice a little more to have a predictable outcome. And it has a very good safety and vision recovery. As it said, like a comprehensive ophthalmologist can manage a severely progressive glaucoma in this kind of situation. But we need more data. Let's come to the new, the probe. A few points about the new probe, the P3 probe. So Dr. Satyan showed this is the previous probe. This is like a minivan. It's like huge. It's, you know, like when you compare it, it's versatile. It's designed for pars plana, and it had a good outcome. But this is the new probe. But this is what you're going to see in next few months. So when you see this probe, looks like a foot plate of an ostrich. It has like almost like two bunny ears, and there's like a soft sole here. But if you know that ostrich is one of the fastest birds on the earth, it can run almost like 45 miles per hour. That's exactly what happens when you place this probe on the globe. When you compare it with previous probe, that I've been using this probe since last October, this is much more smoother. And then like it has a very good advantage that like it kind of like sticks on the globe, and it has some sort of like, I'll show it to you. So if you see, this is the tapered edge, this is like almost looks like a sports car. And this is like the back side, and this is the bunny ears that goes towards the limbus. The main advantage is the curvature. The front curvature kind of like blends with the limbus, and then the probe, the back curvature blends with the sclera. This way that like you have more like contact of any kind of like viscous interface that you're using. One thing that I've noticed is the side effects, the complications, ocular side effects, ocular surface side effects that you very typically might notice in the first probe. You won't see this because the direction of the laser is more towards the exact point where you want to have the advantage. It's not kind of like focused towards the cornea or to the ocular surface. That's one major advantage I've noticed. But there is one thing that I want to caution you is because it's much more ergonomic, it can go really fast. Like, you know, so this is where like my experience is you need to slow down because the probe is designed so smoothly. Like I'm not using any lid speculum. All you have to have is like, you need to have plenty of viscoelastics there and then go slowly, like almost like 10 seconds per hemisphere. And the variable is, before I used to use 80 seconds, now I use 50 seconds. That's the variable, major variable that I'm doing. And so to summarize, one of the major things that like I want to see in my patient practice is, if you see the MicroPulse, that's kind of like, it's been used before the incisional surgery. In my patient population, it's kind of like going into a phase where I'm trying to use it before MIGS. But if you look at those patients who underwent cataract surgery, those are the patients that like who had some sort of like a blood-based surgery later. Thank you.
Thank you so much, Dr. Cyril, for your wonderful presentation. We have a couple of questions before we go to the next speaker. Anyone can answer this? Expected onset of IOP reduction post-laser therapy. Would you like to take it up, Dr. Cyril?
So that's a very good question. Like, you know, in terms of, you know, the IOP drop, you typically see it probably like in a day in most of the patients. But like I kind of like wait for some sort of like a decision to say to my patients that this procedure is not working. I looked into my patients' data, then we wanted to see when would be the best time to decide, you know, this procedure is not working, then we need to go ahead and consider a repeat or we need to consider something different. So I typically, what I've noticed is in 6 to 8 weeks, and if, like, you know, by 2 months, if you don't see a best outcome, by that time I kind of like decide we gave enough time for the IOP reduction for this procedure to work. If not, then I will move on. So it can
Yeah,
start from immediate time, or like the best outcomes can be seen up to like 6 to 8 weeks. I won't jump until like 6 to 8 weeks, or at least for 2 months before I would, decide on something else.
Yeah, thank you, Dr. Cyril, for that answer. And we have one more question: is it safe in high myopic patients?
Yes, it is safe in myopic patients. Basically, like we have to understand how the pars plana is designed so that we don't cause much of a complication. So, like when we're actually placing the probe and then like you're going 1 millimeter behind the limbus, and like when I look into my patient's data, it is safe in myopic patients.
Okay, thank you. Well, we have less time, so we'll have the questions done later. I'm just going to introduce Professor Philip Bloom. He's a professor and a consultant at the Western Eye Hospital in UK. He's going to talk to us about what COVID-19 has taught us about the MicroPulse.
Thank you very much. I'm honored to be part of this auspicious faculty. And I'm going to be talking about this treatment, which is very close to my heart. I've been doing laser treatments with the diode for many, many years. I think they form an important part of glaucoma practice. Many of us have complex glaucoma practices. It's useful in those patients, but it's equally important and useful in patients whose glaucoma is much more, you might say, straightforward or routine. I work at a number of hospitals, and I have a number of affiliations outlined on this slide. I have no financial declarations of note. I'm not a paid consultant. And yes, I'm excited, as I mentioned, to be part of this faculty with this very, very interesting program. I myself am going to be talking about refractory glaucoma. We tend to use this treatment mainly for that indication, but we found it invaluable in these difficult times, as I'm sure many other people have. And I'm going to discuss that with reference to a couple of tricky cases that we've been managing in the recent past. I've had a reasonably close allegiance to diode laser treatments in total since I first did my fellowships at the Western Eye Hospital where I work, and at Moorfields Eye Hospital, where the term cyclodiode was performed. This is, of course, the G-probe in the past. I did my first treatment with that machine in 1994. I know I'm younger than I look. We published a large series in 1997, and we've continued to publish and discuss these treatments ever since. Myself and a number of my fantastic colleagues at the Western Eye Hospital, including Faisal Ahmed, Laura Crawley, and Sally Amin. The issue of transscleral laser treatment as an outflow procedure isn't that new. In fact, I referenced it in an editorial I wrote in the British Journal of Ophthalmology almost 15 years ago, and that was referencing a paper 15 years before that. So this isn't a new thought, but actually I think it's a very good thought, and I'm very pleased that this new technology has shone a light on this important outflow mechanism that I think has been really overlooked in the past. I have been an early adopter, as I mentioned, of diode laser treatments in general. I've long advocated the use of cyclophotocoagulation earlier in the management paradigm. And I've also advocated combining inflow and outflow together. When I say I've advocated using it earlier in the management paradigm, I'm old enough to remember, as I mentioned at the top of this slide, cyclo-YAG. Now that was a very aggressive treatment. Before that, of course, came cyclo-cryo, and many people's historical objection or reticence to the treatment of cycloablative or cyclomodulatory treatment, as I like to call it, goes back to very bad experience with much more aggressive forms of ciliary body treatment. And I think it's very important to lay those in the past where they deserve to stay, because these are brand new treatments with brand new outcomes. So of course, this is the treatment formerly known as a number of different things. I'm an old boy, and I find it difficult to change. I've been asked to call this treatment the MicroPulse P3 device, as opposed to many of the other confusing terms, Suffice it to say that I apologize if I misspeak and say the wrong word in the excitement of this presentation. Just to show you here, this is a graphic from the original 1997 publication showing the transscleral treatment, and this is a more recent publication with my colleagues at the Western Eye Hospital, showing similar sorts of results in the early stages, but perhaps fewer complications. It's a better tolerated treatment, etc. So, MicroPulse transscleral laser treatment in the treatment of refractory glaucoma. I've mentioned the historical reticence to Siri body treatments in general, and for many there is still a perception that this is a treatment that is for blind eyes, for blind painful eyes. I'd like to lay that to rest. We often treat sighted eyes. We often use this as a primary treatment in patients who have not previously undergone any other form of incisional or indeed any form of surgery. And I think part of the problem is that the end stage of glaucoma is sometimes of very poor outflow through the normal conventional channels. And if you try and reduce inflow in that situation, you're really on a hiding to nothing. A much more effective and logical strategy would be to apply the treatment much earlier when your effect on either the outflow via this new route that's been described, or indeed on inflow with the older machine or with the G-probe attached to the new machine is much more likely to work. And I think this is the direction of travel here is very similar to other minimally invasive treatments. Many people are heading towards minimally invasive surgical treatments as opposed to incisional treatments. Of course, SLT laser over drops, and now we're moving towards this MicroPulse transscleral laser treatment versus the old cyclodiode. But I think that, and I think it's widely acknowledged, there is still a place for the other treatment, and it's good, in fact, to have both treatments available in the same, potentially in the same machine. So before I go to these case presentations, I'd just like to summarize the sorts of things that we've learned, the sorts of lessons we've learned in these very difficult times. We have found this effective, simple tool to be invaluable in these times. We found it to be a safe alternative to incisional surgery, with, very importantly, the reduced need to keep bringing patients back. That's a key issue. If there's a cumulative risk that they might contract COVID with many hospital visits, the fewer visits they can make, the fewer their risk. And of course, many of our elderly patients who are self-isolating at home really feel very uncomfortable about leaving their home at all. And this allows them to leave it for perhaps just once for a very short treatment, go back home and actually not need much post-operative management. We found it to be highly effective. Our publication in Von Graffi's shows that. In our hands, it's a relatively short-term efficacy, and I would acknowledge the need to repeat treatment, but there can be many patients in whom the treatment is prolonged. And of course, it's because it's a treatment with a very good side effect profile, there is something to be said for fractionating treatments and perhaps planning to repeat treatments, if you like, considering it a course of treatment rather than a single treatment. I think there are some patients who will not want to undergo incisional surgery, but I think it's very important for us as comprehensive glaucoma surgeons to acknowledge that there will still be roles for more incisional and aggressive surgery. And I think that's important, because I think if we use treatments to the nth degree without moving on if they're not working, that's how a treatment gets a bad reputation. This treatment has a very good reputation because the company, I think, has implemented it in a very sensible way and taught everyone very well and suggested indications for use in an entirely appropriate manner. It is uncomfortable, but it's much less so in my experience than standard TSCP, transscleral cyclophotocoagulation or cyclodiode, and there are fewer anesthesia requirements. We still do use periocular anesthesia, but there are some who just use topical or lidocaine gel. We don't have a lot of experience of that ourselves. And as I mentioned, then there is still a place undoubtedly for transscleral G-probe treatments on the specifically targeting the inflow to a greater degree, and perhaps as well as or as a second stage after this treatment. So I'm going to go on to a couple of case presentations of the MicroPulse transscleral laser treatment. this is a treatment of a patient with angle closure glaucoma, a young 48-year-old lady presented a few weeks ago to the Western Eye Hospital A&E. That's what those abbreviations mean. Classic presentation of angle closure glaucoma, longer history in the left than the right, and presented with very symptomatic, poor vision, very high pressures. The history was sufficiently unusual for imaging to be felt necessary to exclude an intracranial cause for the pain and headache, but there was nothing found. And this patient was very resistant to conventional medical treatments. The corneas were too cloudy for laser iridotomies despite repeated attempts, and the pressure would come down on admission. Then overnight the patient would go home. We try not to admit patients overnight, and the pressure would be high the next day. Eventually we decided that enough was enough. The patient was very symptomatic, and we felt that the appropriate treatment, and this is of course in the COVID era, although she was young, was, and we're still able to do incisional surgery, but we'd rather not. So we performed the transscleral laser treatment. Our standard criteria are 80 or 90 seconds per hemisphere with sweeps of 10 seconds. So in this patient, we applied 9 sweeps of 10 seconds per hemisphere at these settings under periocular anesthesia with sedation, and the treatment proceeded very, very well. On day 1, the pressure had come down. The corneas were still somewhat cloudy. The vision hadn't fully improved. But by day 3, the pressures were both down to very acceptable levels. Pain had resolved. There were a couple of hyphemas in both eyes, either as a result of the underlying condition and its or the numerous attempted laser iridotomies, or perhaps some inflammation, because of course this is a very inflamed eye, and eyes like this are prone to put out inflammatory mediators. And these are just photographs of the patient on day 1, showing a much clearer cornea. This is the Medisoft electronic patient record, which produces a very nice representation, which our unit has described as the Glauco chart and published. My colleague, Professor Cordero, received an award for presentation of this new rationale of looking at things. You can see all the drops here, the pressures, the time frame, both eyes. And it's a very useful way, and you can, in a very graphical way, note the immediate effect of the laser treatment. Granted, this is a very short follow-up, but of course that's a necessity because this is a very recent case. Another case, post-penetrating keratoplasty glaucoma. This was an 87-year-old Caucasian male who'd had a graft, full-thickness graft 2 years ago. Very intolerant of medication, raised pressure, and in view of, we wanted to avoid any incisional surgery, performed the MicroPulse laser treatment with really very gratifying effects. This here is 6 weeks follow-up. And again, here is the image showing that the pressures responded following the laser treatment. And a third case, pseudoexfoliative glaucoma. This was an elderly man, a patient of my colleague's Faisal Ahmed. Thanks for Faisal for that, for allowing me to present this. Had failed a CyPass implant after some time, medically uncontrolled pressure, and really steadfastly refused any surgical intervention, wasn't suitable for acetazolamide, had the MicroPulse treatment, and now the pressure is much more well controlled with very few side effects. Patient's still on medication. So a couple of 3 cases, just a sort of a panoply of different types of presentation and indications for these treatments. We have to judge risk and benefit. There's no doubt that the risk of incisional treatment is no longer just the risk of the treatment itself, but the risk of bringing the patient to hospital on numerous occasions, perhaps suppressing their immune reaction with various medications. And so I think now in the new COVID era, we have to treat patients differently. We have to look at them in an entirely unique way. We've previously struggled to explain risk and benefit, but it's extraordinary the extent to which looking down the barrel of a fatal disease has actually does actually concentrate our patients' minds. And I find that now they are helping me put risk and benefit into clearer and sharper contrast. And on many occasions, I think I've learnt from them. We have great trouble bringing our patients in, and even if a patient consented to a trabeculectomy, I have no doubt that they would often default their follow-ups. And arguably, if you don't follow up an incisional surgery often enough, there's probably no point having done it because it may fail. We don't know the effect of other future variables, and so I would urge you to consider using this very simple, safe and effective treatment with a lower threshold at this time, and perhaps continue in the future. I just make a few points that we've never really faced a challenge quite like this. There's been an enormous but quantifiable financial cost, and of course a completely incalculable human cost with loss of life, limb, and sadly some senses. But I have been extraordinarily impressed and amazed at the unfeasibly swift way that the human population has adapted with broadly effective measures. And it's starting to appear now that some of the changes, some of the new challenges will produce better care in the future. Not now, perhaps, but as time goes on. And I think this may be one of those situations. We may acknowledge that treatments like this that are minimally invasive are ultimately better for the patient than much more aggressive treatments. I'd like to thank you for watching. I'd like to thank my fantastic colleagues. I'd also like to thank Ahmed Al-Nawari, who helped produce some of these slides. And I thank you for your attention.
Thank you so much, Dr. Professor Bloom, for your excellent summary, especially because many people think that it is going to be just the replacement for the trabeculectomy. It is not so. So people should remember this is just not the replacement, but it can be used very effectively in what Dr. Professor Bloom has showed. So that's important. As we don't have much time, so we'll have the discussion a little later. We have Dr. Sonal from India. She's going to talk to us about the two-year experience with the MicroPulse TLT. And also she's going to just talk to us about some of the precautions that you must take care, and also when you can do the retreatment and its effects. Over to you, Dr. Sonal.
I thank IRIDEX for this opportunity of sharing a platform with such esteemed panelists. And I will be presenting our 2-year experience with MicroPulse TLT, our work in progress. Our study was a prospective interventional case series of 92 patients with refractory glaucoma. The baseline intraocular pressure was 31.98. 92 patients completed 12 months of follow-up, 76 18 months, and 28 patients completed 24 months of follow-up. The average timeline was 16 months. Visual acuity of 618 or better Snellen's chart was seen in 27 patients, and 624 had, 13 patients had vision of 624 to 660. 10 of our patients had just one functional eye which underwent treatment. All 92 patients underwent standardized primary treatment. This was 2000 milliwatts, 31.3% duty cycle, and 160 seconds of treatment per eye, which translated to 100 joules per treatment eye. Day 1 saw a dramatic drop in intraocular pressure at 44.5%. On day 7, there was a maximal drop across the study at 53%. And at 6 months, the pressure drop was 41%. Then it plateaued at 35% from 12 months across 18 and 24 months. We also categorized the pressure drop into 3, greater than 30, 20 to 29.9, and less than 20%. At the first month, 83% had greater than 30% drop, and this value was 70% at 6 months. Thereafter, we saw 10% attrition across 6 months, that is 62% at 12 months and 54% at 18 months. And as you can see in the bar graph at the end, at 24 months, there were equal number of patients in all 3 categories. Our success criteria was intraocular pressure between 6 to 18 millimeters of mercury and or a 30% drop, and our success rate was 67%. We juxtaposed our study with peer-reviewed published clinical studies. to get a better perspective, as also to compare our percentage of intraocular pressure drop and our success rates. Drop percentage across the studies varied from 27 to 51%, and most of them averaged between 40 to 55%. Our study is shown in gray is a 35% drop at 16 months timeline. Comparing the success rates of the different studies was a little like comparing apples to oranges due to the variation in the success rates. However, most of the success rates ranged from 67 to 75%. And again, the graph in gray shows our study with a 67% success rate. We also looked at the trends in the different subtypes of glaucoma. In primary glaucoma, we had intraocular pressure drop of 22 to 27%. And neovascular glaucoma did better with a 40% drop in intraocular pressure. Our reduction of topical medication was 3.6 to 3.1. Oral acetazolamide could be stopped in 17 out of 22 patients. Retreatment in our study was 26% of all cases, out of which 22 patients underwent 1 session and 2 cases 2 sessions of retreatment. The timeline ranged 3 months to 12 months post-procedure, and most of the patients underwent retreatment between the 3rd and the 6th month. We categorized retreatment into 2 groups, enhancement and management of attrition. In patients with suboptimal intraocular pressure drop, we retreated with the hope of enhancing initial pressure drop and faced 5 failures out of 9 cases. In patients with initial target intraocular pressure reduction, which showed an updrift of pressure over time, we retreated to manage this attrition. And here we had 8 patients with success out of 15 and 3 additional patients of qualified success. Again, retreatment across the studies ranged from 5.8 to 35%. Coming to the adverse events in our study, we had corneal epithelial defect in 2 patients, one of whom required a patch graft. 5 patients had uveitis, which was controlled with topical steroids and came under control within 1 month post-procedure. We had 2 patients of pupillary mydriasis with accommodation difficulties noticed between 1 week to 10 days post-procedure. All these, both these resolved between 3rd and 4th month post-procedure spontaneously. We had 1 patient of macular edema, which persisted throughout the study period up to the end, and 3 patients had hypotony, which resolved within 3 months post-procedure. We also had 2 patients of optic atrophy and vision loss of greater than 2 lines in 4 patients. Here's an example of the hypotony patient, an advanced primary angle closure glaucoma with 1 functional eye, best corrected vision of 660 and an intraocular pressure of 30 millimeters of mercury on maximal medication. On day 8, he developed hypotony with severe uveitis and vision dropped to counting fingers close to face. He was treated with oral and topical steroids, and pressure climbed between the 2nd and 3rd month to 16 millimeters of mercury, with restoration of vision back to baseline 660 at month 3. In our study, we found that higher energy parameters, if used for enhancement, were associated with greater number of adverse events. Intraocular pressure drop is closely related to amount of laser energy delivered. However, this also translates into greater risk of adverse events, as seen in the 2 highlighted studies where pressure drop, which was pretty dramatic, 41 to 51%, was also associated with larger incidence of adverse events such as vision loss greater than 2 lines and uveitis. So in our search for ideal parameters, we need to balance the success rate with our complication rates. And Sanchez et al. Have hypothesized that this sweet spot lies between 112 joules and 150 joules. Adverse events in patients can be due to patient factors such as the severity of glaucoma, other ocular comorbidities, iris pigment, and race. And the dictum in procedure would be less is more. A few titration tips to tailor treatment: more the pigment, lower the power; better the vision, lower the power; greater the intraocular pressure, higher the power; and more severe the disease, higher the power. So the mantra to optimize the utility of this therapy would be to maintain safety first while titrating treatment to master efficiency. This is a patient with neovascular glaucoma in a 47-year-old poorly controlled diabetic male with nephropathy and an adequately treated proliferative diabetic retinopathy. His left eye vision, best corrected vision was Snellen 660 and intraocular pressure was 54 millimeters of mercury on maximal treatment including oral acetazolamide. On day 1, his pressure plummeted to 12 millimeters of mercury. He had severe uveitis, which was controlled with topical steroids over 2 weeks, and oral acetazolamide could be stopped. At month 3 and month 7, his pressures ranged between 11 to 12 millimeters of mercury on 4 topical medication, and the vision was retained in his left eye, which became his only functional eye till his death at month 8. So in conclusion, saving the vision of one patient cannot change the world, but for that one patient, the world can change forever. Thank you for your kind attention.
Thank you, Dr. Sonal, for your wonderful presentation. I think you have answered most of the doubts that probably the people will have. As we don't have time again, I would request Dr. Alka Panda to present her experience with the MicroPulse therapy treatment. And once she's done, then we'll have the questions answered. Over to you, Dr. Alka.
Today, I'm going to present 2 clinical cases where the MicroPulse device was particularly useful. The first case is that of a 39-year-old lady who presented to us with severe pain and inability to open her eyes properly. She had a history of blunt trauma to her left eye with a tennis ball a year ago, and following which she had a scleral perforation which was repaired, and then she had an extracapsular cataract extraction, and then she developed secondary glaucoma. And when she presented to us, she was on oral and 4 topical anti-glaucoma medicines. On examination, her right eye was essentially normal, but the left eye had very poor vision of finger count close to face. The pressure was high, 28 millimeters of mercury. She was on twice-a-day Diamox and 4 topicals. The cornea was very hazy with bullae superiorly, and a superior sclera where the perforation was there, it was very thin and scarred. There was also severe recongestion present. So this is how bad her eye looked. Look at the left eye. We all know that raised pressures can develop after open globe injuries, especially if the sclera is involved. And if there is lenticular damage, these patients often need surgery to control the pressures. So in our patient, she was in too much pain due to her decompensated cornea with bullae. Her pressures were very high despite the oral and topical medicines. So naturally, the most logical thing to offer her was surgery. But then look at her superior sclera. Was a standard trabeculectomy really possible? Such a bad scar in the superior sclera was very thin. It can almost see the uvea popping out. The next thing to consider in surgery was tubes. But then those were too invasive a procedure in the eyes with such low visual potential. But to top it all, this patient was against any kind of surgical intervention. She did not want any surgery whatsoever. So of course, we offered her the MicroPulse transscleral laser therapy. And because her superior hemisphere was damaged, we did the laser in the inferior hemisphere only. The power settings were 2000 milliwatt, and 2 cycles of 80-second duration was done in the inferior hemisphere only. And this is what her post-laser pressures look like. On the day 1, the pressure decreased from 28 to 8, and she was still on Diamox. So we stopped her BD Diamox and we made it OD. After a week, we stopped her Diamox altogether. The pressure was 8. After a month, the pressure was 12 on 4 topicals. And this was after 2 months, the pressure was still 16. And luckily, today in my OPD, she landed up again at the 6-month follow-up. And this is how her eye looked. It had become quieter. The bulle had disappeared. The pressure was 21, and she was on 3 medication. So that is the success story. She was a very happy patient today. The second case is that of a 46-year-old lady who presented about 6 years ago with complaints of pain and redness. She had a history of cataract surgery about 30 years ago when she was a young child of 16. She was on dorzolamide eye drops on and off in both eyes for the last 2 years. On examination, she had pseudophakia. Her vision was good, but her right eye pressure was very high. It was 35 millimeters of mercury, although her cup test ratio was 0.4. So she was started on oral and topical anti-glaucoma medicines, but then she was very irregular with her follow-ups and her medications. She presented many months later with pain in her right eye again, and this time, though her vision was good, but her pressure was 54, and she was not using any medicines whatsoever. Her corneal thickness was 614 microns, and gonioscopy showed a 270-degree peripheral anterior synechia. The cornea was clear, and there was no evidence of any posterior segment inflammation. And this is how her pressures behaved over the next few months. Whenever she took some medicines, oral medicines, her pressures came down. And then after a few months, she stopped those medicines and the pressures again rose. This took a toll on her visual fields also. As you can see, the visual fields in 2014 is absolutely normal. But the 2018 visual fields shows a definitive scotoma. Even her discs had increased from 0.4 in 2014 to 0.6 in 2018. Her left eye was still normal. So we have a 46-year-old lady here with pseudophakia. She has a history of intermittent IOP rise in her right eye, but a strong history of non-compliance to medication. She had 270 degrees of peripheral anterior synechia on gonioscopy, and she has definitive disc and visual field changes. So then, again, we offered surgery to her. She strictly refused any glaucoma surgery to lower the IOP. But she thankfully agreed to the MicroPulse. So with the standard parameters, we did the MicroPulse transscleral laser therapy on her right eye. This was the post-laser result. The right eye pressure had dropped to 15 on day 1 with some inflammation, 15 at 1 week. At 1 month, it was 20, and the AC had become quiet now. And at 6 months, on 2 topical drugs, she was maintaining a pressure of 18. And the thing to note here is that her vision was very good. It was still at 6/6 paths, which was the pre-laser vision. So that is very important. She was really scared about her vision, but thankfully her vision was stable after the laser. So to conclude, MicroPulse transscleral laser therapy is a good option to control pressures in patients who are poor surgical candidates for glaucoma surgery, like our first case of trauma, or patients who are non-compliant with topical medications but are still progressing, like a second case. And also a second case highlights that this laser can be used in eyes with good vision without any detrimental effect. So at least we know there is still hope for such eyes. Thank you. Now we can take questions.
Thank you for your presentation. Now we'll have the discussion, and I would request Dr. Cyril and Dr. Philip Bloom to take a few questions, especially on the pupillary dilatation and the myopic eyes. What's your experience over there? We have had the pupillary dilatation in some of the patients. So what's your experience and how would you really overcome that?
I'll address that first, if I may. We have too seen a few cases of pupillary dilatation. In one case, long-standing, but in other cases, and it has been reported in poster form at various meetings, taking up to 6 months to fully recover. I think the feeling is that it may well be due to probe orientation, and that with a new probe and a slightly different orientation, it may be less common. Of course, one of the advantages of the old G probe was its nice curved configuration whereby it conformed to the wall of the eye, and the new probe seems to have a very similar advantage, so may mean that the obliquity of the laser is controlled and it's directed more to the tissue where it is intended rather than perhaps the vasculature and nerve supply of the sphincter, which may get damaged in that way. If I could briefly just talk about myopes, we have just a normal share of high myopes. High myopia is not enormously common in London, but we've done a lot of myopic patients. I would say this is a non-thermal treatment. The chance of scleral perforation is next to none. It's a treatment where you're sweeping the eye very regularly. There's no chance for, as there was with the older treatments, of a burn propagating and going through the globe. So I think in strong contradistinction to the transscleral treatment, the MicroPulse treatment is extremely safe and likely to, unlikely to have any problem with the sclera in these myopic patients. I would reiterate the need to identify the position of the ciliary body. Personally, I don't apply treatments slavishly with reference to the limbal anatomy. I always try and identify where the ciliary body is by transillumination, and of course in myopic patients, in pediatric patients, in patients who've had numbers of previous surgeries, the ciliary body cannot be quite where you expect it to be. So I think that's always a useful addition.
Dr. Cyril, your comments? Thank you, Dr.
I agree with most of the comments, like Philip kind of clarified. The major thing in myopics is we have to be very sure about the anatomy, where exactly you're focusing your energy. We need to be a little more, posterior, or like if you are going to focus on the ciliary body, that's where you need to be a little more understanding of the anatomy. The next point is, in terms of complications of scleral thinning, I've done a little more than 400 of this, and probably like 10% of them are eye myopic with greater than 5 diopters. I've not seen in even one case of like scleral thinning or perforation, anything like that. But so I think this is an entirely different technology. The energy is far more safer that is delivered to the sclera or even the ciliary body. The kind of complications that's kind of we used to see with the continuous wave, we hardly see it with the MicroPulse. In terms of pupillary abnormality, like we looked into our, again, a little more than 400 patients' data, and then we wanted to see who actually gets this pupillary abnormality. We typically saw patients in their 50s, 60s in that range, and female patients, and pale. And patients who had like brown pigmentation or Hispanic population in our patient group had more of pupil abnormality. It's almost like 1 to 2% of our patient population had some pupillary abnormality. And most of our patients resolved. Maximum is 6 months. We just kept them on steroids for some time, and then we tapered it, and most of them resolved. We didn't see very active iritis or anything in these patients, but for the pupillary abnormalities, we just kept them for steroids for a little bit longer, and then most of them, within a matter of like 6 months, they resolved. So I don't know your experience, with possibly you might be seeing more patients there with this abnormality in younger patients. I typically keep them on steroids, and then it resolves on its own.
We had about 6 patients with the pupillary mid-dilated pupils, but most of them had come back to normal in 3 months' time approximately, or 3 to 4 months' time. Some of them, I have given them pilocarpine to constrict the pupil, and these patients had come back to normal probably a little quicker than those whom we have not given. So I really don't know. Is it spontaneously they have recovered, or is that pilocarpine really has helped? Because the numbers are pretty small, so I cannot comment on that. But few of these patients, at least, they have responded very well for the pilocarpine therapy. And there are other few concerns that, especially in the pediatric eyes, is that you take up this procedure as a primary procedure in the congenital glaucoma patients. Have you done that?
Unfortunately, like I have my practice where it's typically adult patients. I have no experience dealing with the pediatric population, but
What
I'm
I'm
not sure.
talking is the primary, not the primary congenital glaucomas, those with the secondary congenital glaucomas. Have you ever tried to do as a primary procedure?
Again, no, like in my patient population, I've not tried this in those kind of patient population. Philip, do you have that kind of a patient population?
No, no. We in London, it's a very modular service. Children are treated in specialist units, and I don't have a pediatric glaucoma practice now.
Okay, so we have tried in a few of the patients. Of course, they all have had undergone the trabeculectomy with the trabeculotomy or the tubes and traps, but then there's a little bit of a worry because whether it is going to really perforate these eyes. And when you have the scarred areas and also the squirrel patch grafts, the effect, how is the effect in these cases is little has to be seen. These patients might really require the retreatments. So some of the questions were, when do we really go for the retreatments? I think where the scar tissue formation is dense, and also those who have the squirrel patch grafts where you really may not be able to do the TLT properly. These eyes will definitely require. What I have seen is the patients with the post-trabeculectomy is one of the patients who had the best of the results, and also those with the PKPs. What about your experiences? All the panelists can share your experience. Because these are the common situations that we come across. Many of the times we may want to go for the repeat trabeculectomy and we delay, or can we just do this procedure so that these patients will do very well with this itself?
So can I take that? Yeah, like in terms of repeatability, and especially in post patients who had already had a filtering procedure or in a refractive condition, like this is, you know, they're almost like, if you go on PubMed, almost more than 50% of the publications is on refractory glaucoma, the effectiveness of using this in those patients. It's proven, like, you know, you will know the pressure drop is, you know, as you can get it from 20 to almost like 51% pressure drop in this kind of patients who already underwent some sort of like trab or a tube, who already have failed filtering procedures. So in terms of using it in keratoplasty, again, there are publications which showed that this is very it's very safe, and it doesn't cause any kind of like a damage to the keratoplasty, or it can very successfully bring down the pressure. It's again one more publication that came out recently. But in terms of my experience using it, it's like maybe like 1% of my patient population who underwent keratoplasty have undergone this. And in most of the patients, none of them had to like repeat, or like I had to do something else so far.
Professor Bloom, what's your experience with the uveitic glaucomas and those with the post-retinal surgeries, like silicon oil-induced glaucomas? What's your experience?
I'd be very cautious about using a treatment like this in presence of inflammation. But there are great degrees of uveitis. The very aggressive uveitic glaucomas will often need a tube. The less aggressive glaucomas may do well with the trabeculectomy, and the patients who have minimal uveitis may well do well with a treatment like this. So I don't think for uveitic patients it necessarily has an enormous place, but I think certainly in post-retinal surgery, I think it has a very good place. I think these are the complex glaucomas that are difficult to manage by any means. Let's be clear that the complex secondary glaucomas do badly with most treatments. And I think this treatment is, the results are reasonable with respect to those other comparators. In terms of post-keratoplasty glaucoma, again, I think the concern here is the graft and making sure that there's no rejection. We know that what causes rejection is related often to inflammation. And I think this is a real advance over the transscleral treatment, which was often mooted as a treatment. In our hands, the endoscopic treatment may offer some benefits over all forms of transscleral because it may produce less inflammation, but actually in some people's hands that may not be the case. So as I said before, I think broadly, this form of treatment does well with respect to other comparators in the complex, advanced and secondary glaucomas. But I think the challenge is to think and to consider applying it at an earlier stage of all glaucomas, because as I've said, at that stage, there's a much more, you have a lot more latitude in terms of the balance between inflow and outflow. And any forms of inflow treatment or outflow treatment, I think will, are likely to have a greater effect if they're applied properly. So as I would consider using the treatment earlier, and yes, it does well in the advanced and secondary treatments, but I think, you know, often then it's a question of just, you know, trying what you can.
uveitis is a very tricky situation. I know if you look at the information or the publications that's coming out of MicroPulse, you know, there are, you know, physicians who are using it, but it's a difficult balance. You need to figure out how much there is active inflammation. I'm very fortunate to have people like who can help me with the immunosuppression. But if at all I'm going to consider patients with uveitis to undergo MicroPulse, I would be making sure they don't have a steroid response in the beginning. Because my plan is post-operatively, I'm going to bombard them with steroids. Typically, what I do, like, you know, which I don't do is, you know, in the post-op period, like immediately after the procedure, I give them subconj or subtenon steroids, 4 milligram per ml, like even, subconj or subtenon. And then immediately after the procedure too, like they get very intensive steroids, almost like 1 to 2 hourly or Durezol with the NSAID on top of it. And also like I give them cyclopentolate or anything like a cycloplegic. So, you know, but this it definitely has a place, but like you need to figure out, you know, how active the inflammation is, and you're not going to induce more inflammation in those patients.
I would like to thank each one of you for all the inputs that you have given. So I think the audience would have really benefited with all the presentations. Thank you all the panelists. And once again, I would like to thank all the participants for taking their time to be with us.
And it's my pleasure. Thank you.
Messages.